I wanted to just start the talk. So we're going to be talking about medication management, polypharmacy, adverse drug events, and de-prescribing. But I wanted to, for you guys, just to kind of ground ourselves in the talk today, I want you to think about a patient you had recently seen where a medication has complicated the clinical situation, whether a dose wasn't changed from the hospital to the clinic, or just not changed from clinic to clinic visit, or a side effect from a medication, or a miscommunication of how to take a medication, or even a medical error. And I want you to write in the chat how it made you feel, and how it made the patient feel. So if identifying this medication complication, how it made you feel and how it made the patient feel. You guys can also unmute yourself too if that's easier, but just wanted to get you guys thinking about medications and medication complications.
Gabby, you're paying close attention.
I may be missing messages in the chats, but did anyone put anything in? I didn't see.
No comments in the chat.
Okay.
I would say that oftentimes our patients are pretty angry whenever we prescribe a medication that's not, it wasn't meant to be prescribed, or maybe we didn't properly reconciliate medications that we changed in the inpatient setting, and then didn't either communicate it with the PCP, or the patient wasn't really sure about what was changed during a hospitalization. So I think it can be really frustrating, and for a lot of patients, and in elderly patients for a lot of their families as well. And I think as a physician, it also doesn't make us feel very great when that happens.
Thank you. So it brings up a lot of emotions, frustration, maybe anger, makes us probably judge ourselves or think about, what could we have done differently? Thank you for speaking up. So, medication management and medication complications can evoke a lot of different emotions. And so hopefully we will kind of talk about ways in this talk to kind of figure out, so to get a sense of you to be able to create your own way of reviewing medications with a patient and a caregiver to increase your confidence in identifying medication that can contribute to delirium or adverse drug effects, and really to approach de-prescribing medications. So some of the highlights we'll be talking about is polypharmacy, over-the-counter medications and delirium, adverse drug effects, kind of how to do nitty-gritty medication reconciliation. And then really, how do we bring it back to the patient? So how do we bring medications back to patient-centered care and de-prescribing? So polypharmacy is using or having patients on greater than 5 medications, and it's prescribed medications, and then inappropriately being used. So taking more medications that are indicated clinically. More than a third of people over the age of 65 take more than 5 medications. So having this polypharmacy is quite common. And why do we care? Why does it matter? It's because having polypharmacy and more than 5 medications at a time can lead to adverse drug problems like toxicity, drug-drug interactions. It can lead to increased fall rate. It can lead to increased mortality rate. And those are serious side effects that can impact patient care. So it really does matter when we're trying to think about taking care of patients. Have any of you heard of the prescribing cascade? I see some nods. Does anyone want to share some nods? Yes, some nods no. So for those that have nodded their heads yes, does anyone want to be brave and share what they've heard prescribing cascade means?
Where you prescribe one medication and then subsequently prescribe another medication to mitigate or deal with the side effects of the first one.
Yeah, thank you for sharing that. So prescribing cascade is exactly that. So you have a medication, you get a side effect, and you treat that side effect with a new medication instead of kind of being like, oh, that may have been from the first medication. So instead of kind of pausing and saying, is that, you know, is there an offending agent that's causing a side effect you're adding and contributing to a new medication? So the patient ends up with more medications and their symptoms aren't really alleviated. So as a rule of thumb and as a reminder, anytime someone starts a new medication or just has a side effect, we should really look at their medication list to see if that side effect is from a medication or if it's from something else, because sometimes medications are the culprit, and that can sometimes be an easy fix instead of having a big workup in terms of labs, in terms of imaging, or kind of digging down a pathway. So think about medications and think about when your patients are on more than 5 medications and the complications that can cause. So next, I wanted to kind of talk about over-the-counter medications. I think oftentimes we assume that, or patients assume that over-the-counter medications are safe. And when reviewing medications, we forget to ask about over-the-counter medications, and they can constitute a huge part of the medications that patients are on. Can you think of, or if you guys can unmute yourself or put in the chat some medications that are over the counter that patients commonly use that you have seen in the inpatient side or even the outpatient side? What are some common names that come to mind?
Benadryl.
Benadryl, great. We're going to talk about that a little bit later, but I'm so glad you brought that up. What else? Ibuprofen. What else? Tylenol. Aspirin. Great. So you guys are hitting on the big ones. There's definitely Tylenol is a big one. Any NSAIDs, herbal or dietary supplements, I would say, is kind of in the category of over the counter. And those are usually not FDA regulated, and those can have a lot of drug-drug interactions. So it's really important that we not only ask about kind of like the Tylenols, the NSAIDs, but we also ask about topical agents, because they're also over the counter and they're kind of considered a medication that we don't always ask about. Ask about patches. Sometimes people maybe buying lidocaine patches or other patches over the counter, and that definitely is something we would want to know about as their providers. Even oils that they may use, any suppositories. I think hopefully patients will tell you if they're taking a suppository, but they may or may not. So again, really, when we're thinking about over-the-counter medications, think about all types of over-the-counter medications, not just pills, because that is part of their medication reconciliation. So just want to bring that up. And then when we think about medications, hold on. So it's important to think about aging, metabolism, medication effects. So age-related changes happen in the pharmacokinetics and pharmacodynamics, leading to increase in plasma concentrations and greater sensitivities of drug effects and side effects. Does anyone know the main organs that we think about when we think about these metabolic changes as people get older or when they're really sick and when it comes to medications? Which organs do we think about?
Kidney.
Kidney, yeah, that's a big one. Kidney, liver, great. So those are kind of the main ones we think about. And that's because the liver and kidney functions decline as part of the aging process. And so usually it's important to start with medications at lower doses, titrate slowly. If they're as needed medications, PRNs, to kind of space them out a little bit more. Muscle mass can also decrease as one ages, and that can also affect the metabolism of medication, so doses may need to be increased or decreased. Also, when it comes to aging and just medication effects, those with cognitive impairment are can be more sensitive to medications and can have more adverse side effects to certain medications. So the side effect profile can be exacerbated. So that's something to think about also. And also, due to these metabolism changes, it's important to educate patients how to take medications. You guys may do that already in terms of like thinking about Synthroid, to take Synthroid before eating or early in the morning, or spacing out sometimes calcium or iron or other supplements. So this is all applicable and important to remember when we're thinking about patients and as they get older or as they have serious illness and they have liver and renal impairments. So medications can definitely be impacted in big ways. So another important part of medications is thinking about delirium because many, many medications can cause delirium. And this is a list of medications and kind of categories that can cause delirium. This is not a comprehensive list, but a lot of sleeping medications, anxiety medications, pain medications, steroids. I think Dr. Meyer talked about that a little bit in the last lecture. Anticholinergic medications are a huge one, which we'll talk about a little bit later, even antiemetics, muscle relaxants. So it's really important when we see someone that is delirious to also look at their medication list. Have any of you heard about the Beers criteria medication list? I'm seeing a lot of nods. So that is a really good resource that continues to get updated. It is a list that goes over medications to be careful or mindful about in older adults. It doesn't mean that you cannot use them, and it doesn't mean that you should never use them, but it's something you should be mindful of and at least be aware of. And again, with those medications that are on the Beers list, oops, I advanced the slide. That are on the Beers list, you want to make sure that you are starting the lowest dose, you're titrating slowly, you're monitoring for side effects. And that if it is due to medications, you want to try to stop the offending agent because that could help your delirium. It's really important when we think about delirium that we're monitoring for hypoactive delirium. That can often be missed in the hospitalization. So sometimes it can be present and it could be from a medication side effect that we're not really picking up on. So the next thing to kind of talk about is adverse drug events. 1 in 6 adults over the age of 65 will have 1 or more harmful side effects of medications. That's a pretty big number. So it's bound that you've already taken care of a patient that has had an adverse drug effect, or you will in the future. So it is really something to think about. In a study that looked at 168,000 Medicare beneficiaries with hip, shoulder, or wrist fractures, 75% of them had been taking non-opioid drug medications that were associated with falls and fractures in 4 months prior to that fracture. So medications were linked to having that fracture. So it is a huge cost on our healthcare system. It's a huge cost on patients' health, leading to morbidity and mortality. And so it's something we really want to be mindful of. Adverse drug events and related deaths related to this adverse drug events are higher than some common cancers. So it is something that is a lot more common that we often don't talk about and is something we should definitely be mindful of. I want to just emphasize, because I know that we talked about kind of Benadryl and anticholinergic medications were on the list earlier about medications to kind of avoid. It's a huge one that comes up on the Beers list when we think about our older adults. But why are anticholinergics a problem in patients or in our older adults or those with serious illness that have a lot of medical problems? Why do we worry about anticholinergics or medications like Benadryl?
Well, so patients that have dementia, usually one of the mechanisms, especially in Alzheimer's disease, is decrease acetylcholine levels. So the anticholinergic levels of these medications could potentially exacerbate dementia. Also, these medications can also have some CNS depressing effects, so they can increase the risk of falls. And the anticholinergic side effects can also worsen urinary retention. So thinking in patients that have BPH, they could have acute urinary retention. So that's why we have to be cautious, like prescribing medications that can have anticholinergic side effects in elderly patients.
Great, you covered a lot of the points, and I think some of your colleagues had kind of echoed that: falls, delirium, urinary retention, constipation. You guys kind of hit it all. The thing to remember is that anticholinergic properties are in a ton of medications, in anti-allergy medications, in antihypertensive medications, in benzos, and antipsychotics, in TCAs, oxybutynin. So it's in a lot of different medications. And sometimes we don't, even ones that we don't always think about. And so if you, again, notice that your patient is having side effects, really look at the medications. Think about if they have anticholinergic properties, and maybe stop that medication or lower the doses, or kind of weigh the risks and benefits if that medication is really something that is still needed by the patient. There is a tool that's the ABC calculator that I wanted to just let you know about, that it assesses the additive anticholinergic effects for a patient. And so it can assess the burden of the anticholinergic properties, which can sometimes help you figure out which medications you might want to adjust in a patient if you're concerned about this. So I just wanted you to all be aware of that resource. I'm curious, when you guys see a patient in the hospital or in the clinic, can one of you share with us as a group kind of what you do to do a medication review? Or if you're in the clinic, how do you review medications? Do you guys have a system, or what do you guys do?
Well, sometimes you check you check on the EMR, the medications that the patient is taking. Sometimes they have also a list. So you will encourage them to bring a list, or sometimes they bring their medications, their pills. So you'll see if they take, if it matches to what it's on the system. And sometimes they may take something additional that it's not there. And you will ask them, like, when did you start this? Sometimes also, some patients could have been hospitalized in the Mount Sinai system, but they are seen in a different outpatient clinic. So if they were recently hospitalized, you can see the list of the medications there. And you can compare that to the list of the medications that is listed on the electronic medical system in the case that is different. Sometimes they bring family members, and you can ask the family members, as sometimes the patients may not fully remember the medications that they take. Sometimes they come accompanied by the home health aide, and the home health aide will know, will be a better provider of the information in that sense. It just depends on the patient.
Yeah, you're right. It depends so much, and it depends probably on the care setting. And you guys have all become probably really good detectives. You're like, do I need to talk to the caregiver? Who do I need to call to find out more information? Do I need to call the pharmacy? Fatma said, on the ambulatory setting, we look for who prescribed it and when. For opioids and iStop. Yeah. So there are many different ways of doing it. And I'm sure you guys all have kind of your own system. I just want to encourage you to kind of be comprehensive with your medication reconciliation, and maybe encourage you to add a few different aspects to your medication reconciliation, and make sure that really we're doing a comprehensive med rec at any setting. So whether it's in the clinic, hospital, subacute rehab, transitions of care are really important for that. And that's to mitigate adverse drug events. Sometimes, we may have 5 admissions in a day and we're running really short. And I get that medication reconciliations can take a lot of time. However, if it's done correctly, it can often save a lot of time and save a lot of confusion later on, and save technically some morbidity or adverse drug events. So we want to make sure that we're doing a good job. It's also really important for patients to know, for us and them to know why each medication is being taken. And if we're not really sure, and it's a patient says, I don't know why I'm on this, we're not really sure why we're on it, we should question and say, is there a current need for this medication, or should we stop it? And it's really important. Part of the medication reconciliation is to ask how patients are taking their medication, dose, frequency. It's important to normalize the difficulty of taking medications. Patients may not be forthcoming right away, but to say, look, it's hard to remember all of your medications. Like, it's okay if you skip medications. That's really helpful for me to know as your doctor, because that will allow me to better take care of you. So sometimes we may just assume patients are taking it as is listed, but they may not. And so how are they taking it? Are they taking it 3 times a day? And if that's burdensome, how can we kind of improve that? Every time that we see them, we want to assess their health status, specifically their renal function, their liver function. Are they still able to swallow pills safely? If changes in health status are noted, we might want to make adjustments to medications. We will talk a little bit more about de-prescribing a little bit later, but de-prescribing medications is really important for medications that are no longer necessary, for medications that are failing to achieve patient goals, and when the harms outweigh the benefits. And then, if you're starting a new medication, we want to make sure that we're not treating another side effect, like we had talked about earlier, the medication prescribing cascade, or preventing further complications. Also, with medication reconciliation, we want to make sure that part of asking about medication reconciliation is also asking about substance use. So whether that's alcohol, drugs, tobacco, prescription drug misuse. And that's because drug-drug interactions can impact metabolism, and you want to make sure that you are assessing the risk of medications. If you are the ones prescribing medications like opioids or benzos, you want to make sure that if there is a history of substance use, that you're not going to prescribe a medication because of that, but that you're aware of it, again, for the safety of the patient. As a rule of thumb, older adults are generally not likely to be as screened as much for substance use disorders compared to younger adults, but it doesn't mean that it doesn't exist. So those are kind of some things to think about in terms of medication reconciliation. And I don't know if it was Christopher that said, but, you know, also making sure that there's a lot of different providers and trying to check different care systems, but making sure, especially in the outpatient setting, as you guys as residents are going to be primary, you know, you are the primary care doctor, making sure that if there is a specialist that's at NYU or that's at, you know, Hackensack or somewhere else, that we're knowing if they're starting a new medication. So putting it all together. So it's important to think about when we think about medications is patient-centered care. I don't know if any of you have heard of the 4 M's, but it is an acronym or kind of a philosophy of thinking about taking care of some of our older patients put on by the Age-Friendly Health Systems Initiative that focuses on the 4 M's are mobility, mentation, medication, and what matters the most. And the goal of this is improving care for older adults in achieving high quality care. So with what matters most is aligning medical care with patient-centered care and trying to figure out what really matters to patients. And so when it comes to medications, we really want to use a personalizing approach. And so, you know, when we start a medication or when we're thinking about stopping a medication, the patient should be aware of the short-term and long-term consequences, as well as the risks and side effects of that medication. Or if they don't want to take that medication, again, the risks and side effects. When it comes to what matters most, patients often care about their function and often care about their mind. And so if we know that medications may alter their function, whether, you know, they're on a diuretic, they're on a beta blocker that might slow them down or might make them feel dizzy, they might not feel as stable on their feet. That's important for patients to know because that may factor in if they want to take that medication or not. So again, figuring out what's most important to patients and does this medication factor in to helping them achieve what they're hoping to achieve. So by understanding what matters to the patients, you're able to know when to start a new medication, when to de-prescribe a medication, and when to de-escalate the medications. So I want to talk about de-prescribing. How many of you have de-prescribed a medication for a patient? Maybe just raise your hand, give me a thumbs up. Yeah, so it sounds like you all have done that. And have the patients been happy with de-prescribing? Do they feel happy after you do it or neutral?
I have
Don't
had
know.
like mixed reviews. Like some of them are happy to have less medications because they will complain like I take too many medications, but some are so used to the routine that like the de-prescribing like just like messes up the entire schedule and like they don't know what to do, so they resume the medication back again.
Thank you for sharing that. And that's where, you know, de-prescribing is really about the patient-centered care and involving the patient in shared decision-making. And, you know, you can provide a recommendation and, you know, people are creatures of habit. And if they feel really attached to medication, they may go back on it. And so it's really meeting patients where they're at. The idea of de-prescribing is reducing or stopping medications that may cause harm or are no longer providing a clear benefit. We have a ton of guidelines that you guys go over in internal medicine residency, probably on a weekly basis, of when to start a medication, based on cholesterol, based on, you know, what their SCVD risk is, based on their A1C, based on their whatever it may be. I could go on, and you guys could probably list a lot of things of when to start a medication. There are not good guidelines on when to stop medications. And that is something that I'm hoping in your careers there will be better guidelines on when to stop medications, but that's something to keep in mind. And oftentimes when we start a medication, we don't think about a time-limited trial or stopping that medication. So it's something to keep in mind when you start a medication. The reason that, you know, we want to de-prescribe in general is that it can decrease totality, it can make medication regimens more tolerable, decrease pill burden, it can decrease costs, it can also improve quality of life, and ultimately it goes back to what the patient wants. There are a lot of barriers to de-prescribing. I think, Christopher, you named one of them is, what if the patient doesn't want to de-prescribe? And so it's really important that when you're saying we recommend you stop a medication, you're explaining clearly why you recommend stopping it, especially if that patient has been on it for years, or it's from, a prescription from a trusted medical provider that may no longer have benefits and actually may cause harm. That happens a lot when we are transitioning patients to maybe comfort care, or thinking about home hospice, or just thinking about really what is someone's life expectancy and doesn't make sense for them to be on that medication. So a clear explanation of our rationale is really important. You shouldn't just say, okay, you should stop that medication. It needs to be a conversation about that, because some patients really view these medications as their lifeline. They've been on it for years. And so it's kind of negotiating and figuring out, again, how to make it patient-centered care and explaining why you're doing this. And you may need to repeat that explanation a few times. A lot of times medical de-prescribing doesn't happen because of medical inertia, and we kind of just continue meds. We don't always ask, why are they taking it, or even are they taking it? And we just kind of start it in the hospital. And so we want to make sure that, we're really questioning things. We're really getting curious about the medications patients are on. And really that it's not just up to the medical providers. It's not just up to you to de-prescribe. It's working as a team. So it's engaging your pharmacist and the inpatient side. It's engaging nurses. It's engaging community organizers to help you de-prescribe. It's using your interdisciplinary team so that it's not just about you and all of it falls on your shoulders, because it is a lot to do a comprehensive medication reconciliation, to talk about de-prescribing. So really lean on your other team members, whether it's medical assistants helping with, the reconciliation, whether it's nurses talking to patients about what they're worried about in terms of a medication. Lean on other team members, because it can't just be you. That's a lot as a sole provider to do that. I recommend discontinuing one medication at a time for some patients, because then you can see if they're, especially if they're a little wary about being off the medication, because then you can really see if they're doing well off the medication, and that can build the rapport and confidence. Remember that some medications, actually a lot of them, need tapering, or you can have discontinued, you can have withdrawal side effects. So if you are stopping a medication, check and look to see if it needs to be tapered. For instance, of opioids or benzodiazepines or antidepressants or steroids sometimes, or beta blockers. So not that you're just stopping medications, that you're really figuring out if it needs to be tapered. And then when we think about kind of de-escalating medications and when do we do that, can any of you think about examples? So de-escalating, so that's really when benefits of medication for primary or secondary prevention may not be seen at a stage in someone's life. Can you guys think about any medications that fall into this category where the benefits of the medication might not be seen?
De-escalating like GDMT and end-stage heart failure, beta blocker, ARBs.
Mm-hmm. Definitely statins. I love the definitely part. Yes, I agree. What else comes to mind? For our older adults, or those that we're thinking about kind of they have serious illness and they're out of kind of treatment options, maybe for chemotherapy, or they don't want to continue on chemotherapy. What about diabetes? What do we want their A1C to be if they have a lot of medical conditions? Are we okay with an A1C? Do we want their goal to be, less than 7 or less than 6.5? So someone said 8. Yeah, so we have more lenient A1C goals. And even in some people, like if you're thinking about if they're really complicated, you could do less than 8.5. So really looking at where they're at, what their comorbidities are, what their A1C is, what our goals are, and really either stopping insulin for some people, stopping some of the oral anti-diabetic medications. Exactly. Patrick said NOAC and dementia. Yeah, so are they still mobile? What is the hope in terms of preventing, depending why they're on a NOAC? Is it for AFib? Whatever the reason is, kind of weighing the risks and benefits. Exactly. Do you guys use any tools to help you with kind of figuring out prognosis, or if these medications still make sense? Are there any tools you guys use, or is it kind of a gut feeling you go with? Seattle heart failure score for CHF. So I'll make sure that you guys get the slides, because there's some other details in the notes, but some prognostic tools that you can use to help out with this is one called ePrognosis. For cancer patients, you can use ECOG, Eastern Cooperative Oncology Group, or Palliative Performance Scale. Dr. Mulholland might have talked about that kind of in terms of prognostication earlier today, or looking at the Karnofsky Performance Status Scale. There's also geriatric trauma outcome score. There's a lot of different prognostic indexes depending on what their primary underlying medical problem is, but those can be really helpful to kind of ponder in the inpatient outpatient setting. Is it time to de-escalate these medications? What is someone's prognosis, and what are our goals with the medications? So if we are de-prescribing, or if we are de-escalating medications, what do we do with all of these medications? So what is the appropriate things to do? That's a common thing that you may get asked this, or you may not, but I think part of de-prescribing and de-escalating is asking these questions. So some of them, especially if they're opioids, believe it or not, are recommended to be flushed down the toilet, because sometimes it's more dangerous to just throw out a pill bottle. But if you are getting rid of a medication, we recommend mixing the medications with something unpalatable like dirt or cat litter or coffee grounds, putting it in a plastic bag, throwing it away in a household trash, making sure you obviously take off personal information on prescription labels. There are a lot of medicine take back programs. There's a whole movement called National Prescription Drug Take Back events that can happen around the community. Some local pharmacies will take it back, and even you should see in your clinic, I don't know if that's something that you guys already do, but some clinics will have a box of where to put old medications. Do you guys have that in your resident clinic? Maybe that's an initiative you guys can start, but there are a lot of programs within the community if people are looking of where to kind of get rid of medications. But just a reminder, part of de-prescribing and de-escalating is, especially in the outpatient setting, or even if someone isn't coming back home from being in the hospital, what to do with all of those medications. So I just want to highlight a few things that we've talked about today. Really being aware that polypharmacy exists, it's very common, and the risk that it can come along with, mainly being adverse drug events that can lead to increased mortality and morbidity. I would really highly encourage you to do a comprehensive medication reconciliation at every visit. Include over-the-counter medications, whether it's topical, whether it's ointment, whether it's patches, in addition to pills, and ask about substance use, because that definitely impacts medication management. Always start with the lowest possible medication dose. Be aware of age-related and disease progress changes if they have renal failure, liver failure, that if their volume of distribution changes, because that will require changes in dose and frequency of medications. Every medication should have a clear goal. So if it doesn't have a clear goal, maybe it's not needed, and maybe it should be stopped or reassessed. And then bringing it back to the patients, if a medication does not have a clear desired goal, I would consider adjusting the dose or switching it to a more effective agent or stopping the medication. There are some resources here you can use to help you kind of navigate medications and de-prescribing. And then there are also, oops, did I go back? Then in terms of patient medication management tips, kind of things that you could tell your patients is for them to keep an organized list of medications, for them to talk to their primary care doctor, which may be you in the clinic, about any new medications they have from the hospital or from different providers, making sure they're bringing medications in, vitamins, supplement bottles. When medications are adjusting, educating your patients to update their list. And then if a medication, if they notice a side effect, to let you know, and to try to stick to one pharmacy for the ease of medication so that you can build a relationship with the pharmacy if you have any trouble, but also to make it easier for the patient. That may be a little hard when it comes to opioids or restricted medications, because not all pharmacies have them in place, but it is something that we should try to aim and educate our patient or encourage our patients on. There are some references